I'll kind of reintroduce myself while I give you guys a couple minutes to get kind of resituated. Again, I'm Christy Swanson, and as Beth mentioned, I'm a PhD student in the Health Services Research, Policy, and Administration program here at the University of Minnesota. I'm also a Senior Health Services Analyst at the Mayo Clinic in Rochester, Minnesota. And I've been working with this data on and off since about 2011. So without further ado, let's get started. So if this is your first time using these data, you might be wondering, where do I even begin, or how do I get started? Well, it's not unlike thinking through any other research project. First, think about your particular research question of interest and ask yourself, who is the target population that fits that question? So for example, let's say my research question is, what is the impact of using endoscopic ultrasound for staging on treatment patterns and survival in rectal cancer patients? Or maybe I want to examine variation in the uptake of new biological drug therapies for colorectal cancer. With your particular question in mind, you can then begin to identify your population definitions. So for my given examples, that would be limiting to rectal or colorectal cancer patients, age 65 and older, and so on. So beyond obviously necessary definitions such as limiting to your particular cancer of interest and Medicare age, you need to ask yourself whether you also want to consider specific stages, histologies, or other factors. And we'll talk a little bit about all of those. So beyond the technical definitions of your cohort, there are a number of other factors to consider when building out your study population. First, you want to be thoughtful in your cohort definition so that you end up with a study population that has clinical or policy relevance to your particular research question. In other words, you want to make sure that you have the right population for your study. Think about how you can build your cohort in a way that maximizes your flexibility during your analysis. I like to call this the ability to do some slicing and dicing. I like to start my cohort builds by being specific but broad, and then along the way, I might try to create identifiers or flags or subgroups if I anticipate the need for subsetting or stratification, or I think I might need to do a sensitivity analysis later on. And when thinking through these things in an upfront fashion like that, it could help avoid a lot of rework by having to go all the way back to the beginning to adjust any of your cohort definitions. Additionally, I like being conscientious about the generalizability of the study, and you want to do this particularly if you plan to publish your findings, because that will save you some time as well. Finally, you want to think about the timeliness of your study. For example, is a study using patient cases from 15 years ago going to still be impactful? And this ties closely to the concept of considering practice changes over time. You want to make sure your study population is both timely and relevant based on recent practice change, or alternatively, if practice change is actually what you are studying, you want to make sure that your time frame adequately covers those important pre- and post-time periods. So again, these are all just things to keep in mind as you're building out your cohort. So now that we've talked through the thought processes that should be occurring in preparation for building out your sample, let's talk about the actual steps to operationalize that definition. First, you want to identify or select your cases. This kind of gives you that starting group of people to look at. If you think of a flow diagram, I like to think of this as what would be your first box on your flow diagram. Next, you'll want to identify or define your anchor, and this could be the date of diagnosis for your cancer of interest. It could be the date of the first treatment. Identifying this anchor will help you move on to step 3, which is to apply appropriate restrictions. In other words, implement any of your exclusion criteria. Once you work through those restrictions, you can then decide whether your study needs a control or comparison population, and if it does, then you move on to step 4 and work to define that group as well. So we'll first talk through step one in a bit more detail. When you receive your data for your cancer cases, you may need to use a number of different fields to kind of whittle down to your target population of interest. And this is typically done using that PEDS-F file or the Patient Enrollment and Diagnosis Summary file. There's a plethora of data fields in this file to examine. Beth has talked through a number of them already. But first and probably most important is that there are fields to identify specific cancer sites. So you can use those to limit to your breast cancer cases or your lung cancer cases or whatever your cancer of interest is. Other cancer-related fields include those for specific histologies, stages, tumor grades, and others. SEER also collects the age of the individual at the time of diagnosis, so you can use that to restrict to your 65 and older population. Finally, you can collect the quote-unquote date of diagnosis. I say it this way because you won't be given the exact date in the PEDS-F file. Instead, you'll have the month and the year of diagnosis for each cancer record. You, as a researcher, will have to decide what to do with this information. Often, we assign some arbitrary day of the month, for example, the first day, the last day, the 15th of the month. So this is definitely something to be aware of, particularly when you're trying to look at things that happen within a certain time before or after diagnosis. So just be aware that there will be extra work on your part as a researcher to create things like that. So again, now that we have kind of our broad definition of cases selected and our starting cohort identified, we can move on to defining our anchor point. Like I mentioned before, you want to consider where your starting point is for the cases that you've identified. This is going to be necessary for certain studies. For example, if you're looking at survival or time to event analysis, you obviously want to know, where do you start counting that time? This anchor also allows you to define that cutoff between the pre-diagnosis history that you might want to look at and things that happen at the time of or post-diagnosis. As I mentioned, a commonly used anchor is the date of diagnosis. Again, you get the month and the year, so know that if you are going to use that source, that the exact date might be a little fuzzy when you're defining what's pre and what's post. From Medicare, you can also look for specific dates of interest, such as the date of the first treatment, the date of a screening test for cancer, or the date from when a particular cancer diagnosis first started appearing in the claims. No method for getting an exact date is exactly perfect, but you have a number of options for what you could choose for a starting point and how to identify that. Another difficulty with identifying an anchor for your study is that your comparison population might not actually have a similar identifiable anchor. For example, if they are a group that doesn't have the disease or didn't receive treatment, where do you start anchoring those individuals? So it can get a bit tricky, and you might need to think through that a little bit, but we'll talk a little bit more about comparison populations later in this segment. Now we're going to talk through applying our exclusion criteria, and this is probably going to be the bulk of this segment. When you get to the step of implementing exclusion criteria, you really want to use this as an opportunity to consider whether you need to refine your cohort of interest. First, we'll talk through some of the SEER-based restrictions to consider. As I mentioned before, you have a number of cancer-related variables. You may want to exclude individuals with missing workup information. For example, if you have individuals with an unknown stage of diagnosis, do you want those people in your study? And we'll talk through a few of these on the next slide. But you may also want to limit your population based on the reporting source for the cancer or based on the number of cancers an individual has. We've talked a little bit about this in the previous segment as well, when Beth mentioned first and only or first of many cancers. Another possibility is to restrict your cohort to individuals who have survived a certain amount of time. For example, would you want cases who only survived a month or two who may not have even had the opportunity to be treated? Again, these are things you need to think through as a researcher. Remember that SEER collects some very detailed information about the cancer and that you have a lot of information at your disposal. So using these cancer-related fields may help you hone in on your cohort of interest a little bit more. You might use the primary site field to identify, hey, I want lung and bronchus cancer cases, but then maybe you want to use the histology fields to scope in on non-small cell lung cancer. Maybe you are also more interested in the early stage cases of lung cancer for your study and want to exclude the more advanced stages. All of these things you can do with the data available to you from SEER. Additionally, there are a number of other fields that describe the number and size of the lymph nodes examined, lymph node positivity, the grade and size of the tumor. Again, we've talked through a few of these during our question and answer segment previously. So again, there's a lot of rich information to work with in the SEER data that you can use to help refine your cohort and make it more relevant to your research study of interest. I mentioned exclusions based on reporting source. So reporting source refers to how the registry learned about the cancer. When you examine the documentation for the PEDS-F file, you'll come across this list of possible sources within that data field. And as we discussed in segment 1, most of this is hospital-based, so you'll see a lot of reporting sources coming from hospitals, but there are other options for this field as well. And as it relates to exclusion criteria, I'm going to draw your attention to the last two source options on this list. Cases identified by autopsy or death certificate are often excluded from studies that are aimed at evaluating treatment. And this is because those individuals, because they were diagnosed at death, will never be treated. So it doesn't necessarily make sense for them to be in your denominator. So depending on your particular study question, you may also want to exclude nursing home as a reporting source. So again, this comes back to the concept that I'm probably going to repeat a lot during this segment, is that you have to think through your study question and what exclusions make sense for that research question so that you have the most relevant patient population for your study. I also mentioned the idea of implementing exclusions based on the number of cancers that an individual has, and Beth mentioned this as well. And the way you actually operationalize this is based on the sequence number within the PEDS-F file. The sequence number describes the number and order of all cancers that are reported within SEER. And as an example, I'll kind of explain a little bit about the first and only cancer versus the first of many cancer. If we consider an individual who has only a single reportable cancer, say it's breast cancer, and in SEER they'll have a sequence number of 00, which indicates that that person has a first and only cancer. If instead that same individual was diagnosed with breast cancer first and then subsequently diagnosed with lung cancer, the sequence number for the breast cancer would change from that 00 of the first and only, it would change to a 01 as a first of many cancers, which lets the researcher know that the breast cancer is now the first one, but that there are others that the individual is subsequently diagnosed with. This concept goes on, for example, the lung cancer case for that same individual would have a 02 to indicate that it's the second of many cancers, and so on and so forth. As it relates to research, researchers often limit their analysis to first and only or first of many cancers. This often keeps the cohort a little bit cleaner to work with. But again, you have to really think through what makes most sense for your study of interest. Once you get through thinking through the SEER-based restrictions, you don't want to forget about implementing the necessary Medicare restrictions as well. If you plan to follow patients over time, examine survival, measure receipt of any care before or after diagnosis, you will need to make sure that certain requirements are met when it comes to having Medicare coverage. Part A is needed when you want to look at hospital care, care in a skilled nursing facility, hospice care, and so on. You, at a minimum, need to have Part A for these services. However, you also need Part B when you are considering services provided in the emergency department, the outpatient setting. You need to also have Part B when you are looking for durable medical equipment, IV chemotherapy treatments, radiation therapy, so on and so forth. Finally, Part D is that prescription drug coverage again. So you need to look for this when you are looking at either chemotherapy that has no IV equivalent or metabolite, as well as other prescription medications for both cancer and non-cancer indications. In research projects where we're using the SEER-Medicare linked data or Medicare projects in general, researchers often limit to analyses to patients that have both Parts A and Parts B of Medicare, and then they may or may not decide to also have Part D coverage as part of their restrictions. So at this point you might be thinking, why do I need to require both Parts A and Part B? You might be thinking, well, Christy, what if my study is really only concerned with hospital services? Do I still really need to require Part B coverage as well? So what we've done here is create a visual that compares individuals with Part A only coverage to individuals covered under both Parts A and B. We split this out into age groups as well to adjust for that factor a little bit, and what we've done is summarize the percent of individuals within these groups who had a hospitalization. And you can see the disparity between the A-only group versus the A plus B group, and you can see that there appears to be a gap in the Part A-only group. So even for Part A services, individuals with Part A-only coverage probably have incomplete claims that could bias your results. To confirm this point for you a little bit more, we created the same data summary, but we did it for a cohort of individuals that we identified as a known to have treatment group. So here we look at colorectal cancer cases diagnosed between the years 2004 and 2013, who we could identify as being treated with surgery, and we did that based on data fields present in the SEER data or the PEDS-F file. Again, we kind of took the same approach. We compared hospitalization rates using the Medicare data across A-only and A plus B groups, and we stratified that by age. And we see the same pattern here, that we just aren't capturing the number of hospitalizations that we should be in the A-only population. So my answer to your question about your study would be yes, there is benefit to limiting to an A plus B population, even for a study that's mostly concerned with hospital services. Now, keeping in line with this general concept of coverage under both Parts A and B, I'm going to show you a couple more examples of why we might need to ensure that we have comprehensive coverage for all of our study population. So the next couple of slides, we're going to be considering a breast cancer cohort. And let's say we're interested in looking at mastectomies performed for these individuals. It might be really easy to say, hey, I'm going to look into the hospital file. I'm going to look for inpatient stays with one of the procedure codes being a mastectomy. And that's fine, and you're going to capture a lot of procedures, but the purpose of this example is to demonstrate that services may not always happen in the setting in which we expect to see them, and as such, they may show up in a different place than where you expect. So what we did here was take a breast cancer cohort. We looked for mastectomy claims across all three of these files. We did this by looking for relevant ICD-9 procedure codes, which you would need for the MedPAR and the outpatient file, as well as using CPT codes, which you would need for the outpatient and the NCH carrier or physician file. We took all of those claims that we had now pulled, and we just basically summarized them based on where that claim was found. And you'll see that, yes, we capture a lot of procedures in the hospital files, but we also see a decent number appearing in the outpatient file and some in the carrier files. Now, is it possible that some of these services are tied together with a hospital record or a hospital stay? Yes, but some of them aren't going to be. And so we wanted to show you this example just for your awareness again that services may not always happen in the setting that you think they are going to happen. So kind of looping this back around to your coverage restrictions, it's again very important that you require your population to have enrollment under both parts A and B, and that you not only have that cohort requirement of having comprehensive coverage, but that when you're also looking comprehensively in the claims when you're doing your study. So if we wanted to take a comprehensive look at breast cancer care, where would we need to look for these services and what kind of coverage restrictions will that imply that we need to meet? So again, we just walked through the mastectomy example, and given the previous slide, you'll need to have both Part A and Part B coverage to ensure that you're capturing all mastectomies. Next, you'll want to consider you may want to consider other forms of breast cancer surgery, such as a lumpectomy or other form of a local excision. Similarly to what we talked about with mastectomies, you're going to want to have both Parts A and Part B coverage. For radiation therapy, there are a number of codes that you can use to identify those, and we'll talk more about those in detail in segment 4. The bulk of them will be CPT codes, and those will appear in the outpatient and the carrier files, and those will be a Part B service, so you'll need to make sure that you have Part B coverage if you want to look at radiation therapy. Finally, in this table, we have kind of summarized how you would look for chemotherapy treatments. Again, we'll get into more detail on this too, but at a high level, where you look for chemotherapy and how it's covered depends on the drug and how it's available and for what indication it is being prescribed for. So if you have a chemotherapy agent that has an IV equivalent or metabolite, then it will be covered under Part B, and you need to make sure your individuals have Part B coverage. If your drug of interest or chemotherapeutic agent doesn't have an IV equivalent, then it will be covered under Part D, and other prescription drugs will be covered under Part D. So again, this comes back to the idea of sometimes you might need to have to understand Medicare payment rules as well to know what kind of coverage you need to require for your cohort, whether or not you need Part D. And so for comprehensive breast cancer care, you will need to have coverage across all these 3 parts of Medicare. This table also kind of helps demonstrate our point that combining an A-only cohort with an A plus B cohort might get a little confusing depending on where you're looking at these services occurring. And so an A plus B cohort often just makes more sense and results in a more coherent manuscript. So we've talked about Medicare Part A, we've talked about Medicare Part B, we've mentioned Part D, and now we're going to throw in another one. We're going to talk about Medicare Part C, or also known as managed care, as another option for beneficiaries. And again, we kind of talked about this a little bit in segment 1 and in the question and answer segment. So I'm going to talk in a little bit more detail about managed care and why we really want to have that as an added restriction when we build out our cohort. Enrollees in managed care receive all Medicare covered benefits, but again, as Beth mentioned, the managed care plans don't submit or transmit detailed claims to the Medicare program. We'll have it for hospice and we'll have it for Part B. So what can happen then is that for beneficiaries covered under managed care, we won't see most of their services when we look into claims. And so we'll have serious gaps in the remainder of their medical information that isn't Part D or hospice. So this is often another restriction that we impose when we're doing a research study, because we are unlikely to have complete claims for these individuals. And so, for example, like Beth mentioned, we can't be sure whether a person didn't receive treatment or if we just didn't have the claims for the treatment. We don't really know which one it is. One thing to be aware of when it comes to managed care in light of imposing this as a restriction on your cohort is that it's going to affect SEER registries differently, and that's because there is variation in the amount of managed care penetration across registries. What we did here to kind of help you understand that is we looked at cancers diagnosed in 2014 and enrolled in Parts A and B of Medicare at the time of their diagnosis. And then what we did was out of that group of individuals, we looked at the percentage of those individuals that were also enrolled in managed care at that time. And we summarized that information across registries and ordered them for you so that you can see that there's a wide range of how much managed care enrollment there is across registries. It ranges anywhere from about 17% up to 53% about. So again, that's something to be really aware of when you're applying your restrictions, that different registries are going to be affected differently by that restriction. So just be aware of that. In addition to having variation across registries, managed care enrollment has actually varied over time as well. So overall, we've been seeing an increase in managed care enrollment over the last 10 to 15 years or so. And that pattern you can see over time also varies across registries. So some registries have had really large increases in Medicare managed care enrollment in the recent years or over time, and some have only had slight increases. You can also see at least one registry that seems to have some decrease. So when you're considering your population and your time frame, you want to just be very mindful of this concept and these patterns so that you have an awareness and an understanding of what those restrictions imply for each registry and at a certain time point, and be thoughtful about what the implications are for your study. So what all this information boils down to is that basically when you're building a cohort, you want to limit to those likely to have claims. And that's kind of a phrase we like to use, this term of likely to have claims. And basically what that means is that we're restricting our cohort down to individuals where if we include them in our denominator, that we know when we go to look for their services that we likely have a complete picture of their care when it comes to billable services. And these are the people that we would feel most confident that we will see all of their services appear in the Medicare data. So to kind of recap the last set of slides, we want folks 65 years and older at the time of diagnosis, since that's the qualifying age for Medicare. We want folks enrolled in both Parts A and B of Medicare, or if you're looking at survival or rates or time to event analysis, you don't necessarily have to have somebody covered for, an entire year or your entire post-time frame. It might be okay for them to just be covered until a censoring event or until the time of their death. And again, that's study dependent. Finally, for whatever study you're looking at, pre and post, you don't want to have any managed care enrollment at any point in time because, again, you'll likely have a gap in claims. So after talking through that, you might be wondering to yourself, okay, I followed the directions, I'm going to implement A and B, no managed care, but what can I expect in terms of how that impacts my sample size? So we put together some slides here to kind of demonstrate to you what you could expect to see when you limit to those likely to have claims. So this slide takes all cancer cases diagnosed from 2007 to 2013 and looks at the percent of individuals who have full coverage, or as we call it, likely to have complete claims, which means they have Parts A and B with no managed care, and we did this for a year after their date of diagnosis or until the time of their death. And you can see that we've summarized the percentage of those individuals that meet those requirements, and we've done that overall and across age groups for you so that you can see that there's some variability in age when it comes to likelihood of having complete claims, but you get somewhere around 60 to 65% of your starting population once you make that restriction. So I said I was going to come back to this a little bit. We don't want to forget about Part D coverage. Remember that Part D is prescription drug coverage, so if you're going to look at prescription drug therapy, then you need to require Part D coverage as well. I'm going to reiterate this again, and we'll reiterate it again later in a different segment about chemotherapy drugs that depending on their availability, whether they have an IV equivalent or not, they might be covered under Part B or they might be covered under Part D. So what I've done here is we recreated the previous figure that we just showed a couple of slides ago, but we've added a second bar. And this kind of demonstrates to you how that sample size percentage is going to change if we also restrict individuals to have Part D coverage as well. So you see that that blue bar is the same as what was shown 2 slides ago. The percent of the total cohort we'll end up with if we restrict to A and B with no managed care. And then the red bar is the percent, again, of the total cohort if we also require those individuals to have Part D coverage, and that's for the year following their diagnosis or until the time of death. So it doesn't really look like you end up with a lot, but remember that you're dealing with hundreds of thousands of people per cancer case or per cancer in these files. So if you're looking at Part D, you're more than likely still going to have a large enough sample unless you impose a lot of other restrictions, which we'll also talk about. I wanted to display this same information in a slightly different way. So the only difference here from the previous slide is that the denominator is different. So I've summarized those with Part D coverage, but instead of out of the total cohort, it's out of those likely to have claims. So if you were to go from your, I have my cohort, they're A plus B, no managed care, if you were to go from that and then add the Part D restriction, this is the effect. You get about half of those people. Just like managed care, Part D enrollment varies across registries. The degree of variation isn't quite as wide as with managed care, but it's still something to be aware of, again, when you're imposing these restrictions, knowing that how they impact your sample size across registries over time for different subgroups of individuals is important to be aware of. That was quite a lot of information to throw at you in the last dozen slides or so. So what we're going to do is we're going to take a quick pause and we're just going to summarize quickly the common limitations or the common restrictions that we kind of just walked through. So in terms of the SEER-based restrictions, again, there's a lot of great cancer-related fields that you can use in the PETS-F file, such as histology, stage, tumor characteristics. We typically want to limit our cohort to those that were not diagnosed on death certificate or autopsy. You may want to use the sequence number to set that down to a first cancer. And you may want to require that your individual survive, let's say, at least 3 months, so that they have the opportunity to receive treatment. Again, that's going to be study dependent. On the Medicare side, we just talked through all of the different coverage requirements that you might want to consider, but most often we want to require both parts A and B for your entire study time. So this means that if you want to look a year back from the time of diagnosis, you want to require that A and B for that year prior as well. And we don't want managed care or HMO enrollment at any point in time, because even if you have 1 month where they were enrolled in managed care, maybe out of a 2-year period, you still are not going to really know what happened that month, and you're going to have a gap there. Sometimes we might decide we want to limit the upper age of cases. You might have see that there are sometimes some really, what looks like really, really old people in the data, or maybe there are clinical reasons why a very elderly population is not going to be of interest to your study. So you want to kind of consider if there's a specific age range that you want to look at. Sometimes we also limit the lower age range, and that's, again, based on if you want to collect baseline information. So if you want to look a year prior for comorbid conditions or prior treatments or prior utilization, you need to require Medicare enrollment coverage for that year prior. So you're no longer going to have a 65 and older population because the individuals who are 65 won't have that Medicare coverage that year prior. And then again, if you need Part D for prescription drugs, you want to make sure that you have that as well. So you might be sitting there thinking, okay, this concept makes sense, I think I get it, but how long do I actually have to require coverage for? And often, again, this depends on the research study, but if we're looking post-diagnosis, we might want to go at least 6 months, maybe a year, maybe 2 years, depending on the research question. You basically want to think about how long are you going to be looking for care for your individual, and then maybe go a little bit more than that. But it's really important for you to understand how length of coverage restrictions can impact your study and your sample size. So what we're going to do is the next series of slides is going to demonstrate to you how variations in length of enrollment requirements can impact your study sample. And deciding on the appropriate length of enrollment is kind of a balancing act. If you don't require enough, you may never see your treatment or outcome of interest, even if you have a really nice large sample size. But if you require too much, you might have a really comprehensive look at your cases, but your sample size might just be too limited. So what I have here is if we think about, let's say we're looking at cases diagnosed between 2004 and 2015. And the only restriction we require is that our cancer cases are covered at the time of diagnosis. And by covered, I mean parts A and B, no managed care. You get a really nice wide sample. You'll have representation across all your years, and because you're only requiring coverage at the time of diagnosis, you're going to have individuals that may or may not be covered before. You're going to have individuals that may or may not be covered after. So you have this nice big population. But you're limited in your ability to look forward and backwards. So now let's say we also want them to have coverage for that year prior. Let's say we want to control for comorbidities, or we want to control for prior healthcare use. Well, now you've limited your sample size down a little bit because you no longer can have those individuals only diagnosed at diagnosis. You also want them to have the year prior, and they may or may not have the year post. So you can kind of see the impact on your sample size in that first table, that you lose that first row of individuals. How about we want a year post as well? Well, now you lose that second row of individuals that only have coverage at diagnosis and for the year prior. And if you'll notice, our rightmost column drops out. And that's because we now also have to require enrollment coverage for a certain amount of time. And I'll talk about this in a little bit, but your indicators for enrollment only go so far in the data. So to summarize that up, by requiring that additional coverage, you've effectively changed your sample population a little bit. So you said, hey, I want cases diagnosed from 2004 through 2015, 65 and older, with coverage for 1 year prior to diagnosis, at diagnosis, and for a full year after diagnosis or until death. Well, what you actually end up with is a cohort of those 66 and older. And that's because, again, you've required that coverage for the year prior. And then again, coverage indicators only go so far. So for the 2016 linkage, they go through December of 2015. So if you want to require that individuals have coverage for that entire year prior, the earliest case you're going to have is cases diagnosed no later than December of 2014, so that they can meet that year of coverage requirements following diagnosis. So the question then comes like, well, will you ever get anyone diagnosed in 2015? Well, it depends. If you require a full year of coverage, but you say it's okay if it's only until the time they died or only until a censoring event, well then yeah, you might have some individuals diagnosed in 2015, but remember that based on your requirements, anyone diagnosed in 2015 also died in 2015 or also was censored in 2015. So again, just things to be aware of and acknowledging how they may impact your study and whether that's what you want or not. And then if we add another wrinkle, what if you add Part D requirements as well? Well, you see that the width of your population sample all of a sudden shrinks. And so, you know, the thought might be, well, what happened? Well, again, remember from segment 1, Part D data doesn't begin to start being available until 2007. And then again, plus the coverage indicators in the 2016 linkage only go through 2014. So all of a sudden now we're narrowing our time frame of our sample by having that Part D requirement. And then as an extreme example, how about all of the above plus 5 years of coverage? Well, now you've really limited your sample population to about 4 years of cases if you want them to have Part D, if you want them to have at diagnosis for a year prior, for a year post, and then if you want them to have 5 years of coverage after diagnosis, then those cases in 2010, at the end of 2010, need to have coverage in 11, 12, 13, 14, and 15, which is as far as your enrollment data goes. So the moral of the story is that you really have to be thoughtful about your study design, the impacts on your sample size due to length of enrollment requirements, and think about whether that's really what you want in your study. So if we look at a concrete example with some actual numbers in here, we have breast cancer cases diagnosed from 2004 to 2013. We get about 363,000 cases just with that definition alone. And you'll see as we work through some of these common limits that we've talked about, your sample size starts to kind of drop off a bit. And I want to point out where we put the age restriction, the age 65 or older. We kind of purposely put it in the middle here, and you can see that we suddenly lose about half of our cohort here. And this can be kind of like that glasses half full, glasses half empty situation because of just the nature of how we've built out this cohort. Because we've put the age restriction there, it seems like we've lost a lot of people. But again, we've kind of talked about how, you know, you're using SEER-Medicare linked data, and the folks that are under age 65 in this data are going to be those identified by Social Security that are disabled or are end-stage renal disease. So that might be something that you want to start off with, that I want breast cancer cases from 2004 to 2013 who are 65 and older. And that's going to really change what your percentages look like when you're building out your study. Continuing on with the restrictions, again, A and B, no managed care. Part D, we get down to just under 32,000 cases. And you'll see we're at about 8.8% from that starting population. Again, part of that is because we didn't also require that age restriction early on. And that might seem really small, but again, that's 32,000 cases to look at. The other thing I want to point out, just as we saw in the previous slides, is to keep in mind that requiring Part D enrollment implies that your cohort now starts at 2007. Your cohort is not going to start at 2004. So what we did here was we reran the numbers, and we started at 2007. And so you see the percentages are a little bit different. We end up with about 13% instead of just under 9%, but your final sample size is actually still the exact same number. So again, just be mindful about how your restrictions impact what your study definition actually is. So the key takeaways are that your numbers can get small really quickly. The more inclusion-exclusion criteria you use, the more potential there is for your sample to shrink. So there are a number of things you can do to remedy that. You can relax some of those constraints. We talked earlier on about being the ability to be flexible in your analysis. So maybe consider building out flags that you could consider using later on for stratification or subsetting or sensitivity analysis versus incorporating those as a exclusion criteria. You could consider treating missing as a category. There might be some fields, maybe some demographic variables or workup variables that have missing or unknown values. And sometimes the sample size within those subgroups is actually quite large enough to be its own group. So you could consider doing that as well. You might want to go back and add more years of cases, or you might just want to say, I'm just going to stick with this number because they're really well-defined cases and I feel pretty comfortable with them. So we're running short on time, but we have one more step to talk through real quickly, and that's selecting controls. And I know Beth kind of mentioned this a little bit in segment 1, but when you think about whether or not you should use a comparison population, you really have to think about your study question and place it in that context. So for example, if you want to look at, if your study question is whether people with radiation therapy live longer than people without, well, naturally you need a treated and an untreated group to answer that question. Similar for these other examples, does race explain treatment? Well, then your exposure variable is those different race fields, and are hospitalization rates different by certain demographic characteristics or certain treatments? Again, the nature of these questions dictates that you need comparator groups. You need exposed, unexposed, you need treated, you need untreated. So think through your question and whether there's kind of a natural definition of who is the population that you'd be comparing to. So when you're actually considering picking out that comparison population, there are a few other things you want to consider. For example, is it possible that the disease outcome reflects some common biology between the disease and outcome? In that case, you're really going to want people with the same disease. So your cases and your controls have the same disease. Are there healthcare system effects? Well, then you want to pick controls that have the same access to healthcare. Finally, are there treatment effects? Then you want to pick controls who would have had equal likelihood of getting the outcome except for the treatment. So you don't want to compare a group who gets treated, who gets the outcome, to a group who gets untreated, who never would have gotten the outcome. Again, you want to have that equal likelihood. So there's a couple of different options. Again, we talked about the example of radiation therapy, and so if you want a treated versus untreated group, then you could go with they have the same cancer, again, that biology. They have the same disease, maybe they have, again, different demographics, they have different stages, or they were treated versus untreated. You can also consider the non-cancer cases that we've talked about or other cancer control populations. So that would be that 5% sample of Medicare beneficiaries, and then there are the non-cancer samples that did not have their cancer report, that either don't have cancer or didn't have it reported to SEER, or maybe it's the individuals in that sample that have a cancer, but it's not your cancer of interest. So there's a number of different options you can consider based on your study question and which of these options is most appropriate. And when we think about our potential cases, and particularly that 5% sample, that's made up of a couple of different groups. And again, you might have, if you look at the breast cancer cases that you'll get in the PEDS-F file, a number of those cases will also be part of the 5% sample. And there's a flag for the cases that are part of the 5% sample versus those that are not. And so you can identify those. You can also identify any other cancers in the file that are part of the 5% sample. And those individuals are actually taken out of that 5% sample file, and those maybe in the PETS F file. And then in the sum denom file are the remainder of the non-cancer cases. Again, there might be individuals in there that actually have cancer, but that they weren't reported to SEER or it was missed for some reason. But this whole pie that we're showing here, it's actually represented across 2 files. When you're thinking about your comparison population, we talked a little bit about how do you anchor them or should you match them in some way, and a common question is, well, do we just match on year of diagnosis? And that's an important thing to consider, and it depends on the study question, obviously, but there may be secular trends that you want to make sure that you're accounting for that matching on year of diagnosis might help with a little bit, and that might be if staging has changed over time, if there's been new guidelines implemented, coding changes over time. For example, in 2015, we switched from the ICD-9 coding system to the ICD-10 coding system. CPT codes change over time, and drugs may go off patent. So you want to be thoughtful about kind of these secular trends over time. And again, if those are of concern, it might be a benefit to match on year of diagnosis. So to kind of wrap up this idea of considering control or comparator populations, you really want to think about a couple of things. You want to make sure they're comparable except for the factor of your study. So again, we talked about if there's a biological component, you want individuals with the same disease, and then maybe they're treated versus untreated. I mentioned this a couple of slides ago that there might be people in that 5% sample control population that actually have cancer. Beth mentioned that as well, and we've already kind of talked through the reasons for why that might be. And then for studies using race, if you're using the control population, remember that that is a 5% sample that Medicare considers to reside in SEER areas, so your race variables are going to be coming from Medicare. So you want to make sure that for both populations you're using the Medicare race variables for both cases and controls. And then you want to think about that the fact we talked about a little bit earlier of their likelihood to have the outcome. Do both groups have similar likelihoods of having the outcome? And again, we've talked through these other things as well. You're going to need to impose the same restrictions on the control population as you would on the cases. How much time before and after do you need to require Medicare coverage? And do you need to restrict some age based on your anchor or your date of diagnosis? And then considering things like how much time you'll need to look for the follow-up care. If it'll take 3 years for the effect to be seen, then you want to look 3 years. And again, like we've talked about before, then your last case can't be enrolled less than 3 years prior to the last enrollment date that we have available for Medicare. So again, it's just really thinking through the methods so that you have a well-defined case population and then you have a well-defined and comparable control population for your study of interest. So to kind of summarize everything, using SEER and Medicare data together in this linked fashion it's a really powerful way to select a study sample that has comparable demographic and cancer characteristics, but you want to be able to balance that ability to have that well-defined population with your sample size needs. And again, we've talked a lot about how it's a balancing act. So you want to be thoughtful in how you apply your exclusion criteria. You want to understand how it impacts your sample population and what that might imply for making inferences with your research study. And then again, you want to make sure that you have implemented all the appropriate coverage requirements. For example, you want to have Part B when you need it, you want to have Part D when you need it, you want to limit to those likely to have claims. And remember that a lot of these restrictions might vary over time. So just be aware of that as you're building out your study. I know we're a little over on time, but do we have any
We do have a
burning questions?
number of questions, but I think we are just going to table them and follow up either in between if we have some additional time, or making sure that we follow up offline with individuals. We do have a break that's scheduled for right now, having us come back in about 5 minutes, but I'd like to give individuals some time to go and stretch their legs and refill their coffee. So we will return at 10:20 Central Time, and we look forward to seeing you all back then.